All right, let's dive right in. We're about to crack open a medical case that starts with what seems like a simple problem, but you'll see it quickly turns into some classic diagnostic detective work. Welcome to the case of the troublesome ear. So these are the words that kicked the whole thing off. Just imagine sitting across from your doctor and saying that. It's not just an annoying problem, right? It's a 6-month-long mystery with some really specific and, let's be honest, pretty unpleasant clues. This is our starting point. And here's our patient. She's a 64-year-old woman, a farmer, who's been putting up with this for half a year. She's the center of our story, and everything about her history holds a potential key to unlocking what's really going on. Okay, so let's officially open the case file. We're going to treat her symptoms just like pieces of a puzzle. We have to figure out how they all fit together to see the whole picture. Here are the first clues, straight from the source. The hearing loss didn't just happen overnight. It kind of snuck up on her. The file says insidious and gradually progressive. Then you've got this discharge. It's constant, it's yellow, and it has a foul smell. And get this, when she tries to clean it, it actually gets worse. Every single one of these details is a huge clue. So now we're going to shift from just listening to the patient's story to actually decoding what these clues mean. I mean, how does a doctor take these symptoms and turn them into a real theory? Well, it all starts with one really basic question. And the answer to that is a big, fat no. Of course not. And figuring out the difference is the first major step in solving this thing. This one question basically splits the diagnostic path right in two. And that split is between these two main types of hearing loss. On one side, you've got conductive loss. Think of it like a plumbing problem. Sound is literally blocked from getting where it needs to go. On the other side is sensory neural loss, which is more like an electrical problem. There's damage to the inner ear itself or the nerve pathways. But here's the key difference. With conductive loss, if you just turn up the volume, things usually get clearer. With sensory neural, louder is just, well, louder, not clearer. So let's connect that right back to our patient. That little detail about her hearing better when people speak loudly, that is a huge light bulb moment. It points a giant flashing arrow directly at conductive hearing loss. We've just dramatically narrowed down where the problem is. It's not the nerve, it's somewhere in the outer or middle ear. And you know, believe it or not, the discharge itself is basically telling us a story. It speaks a language. Our patient's was yellow, which suggests a bacterial culprit, probably staph or strep. If it had been green, we might think of something else, like Pseudomonas. So the color is yet another piece of the puzzle, giving us a hint about the type of infection we're up against. Okay, so we've picked apart the patient's story. Now it's time to gather our own evidence. We're moving on to the physical exam, where the doctor can get hands-on and start to confirm or rule out our suspicions. One of the first things the doctor's going to do is check for any tenderness in that hard bone you can feel right behind your ear. By pressing on these few key spots, they're checking to see if the infection has spread deeper into the skull, which would be a really serious complication called mastoiditis. Next up are the functional tests, and these are so clever. The first one is called Renee's test. It uses a good old-fashioned tuning fork to answer a very simple question. Do you hear better when the sound travels through the air to your eardrum, or when the vibrations go directly through the bone of your skull to the inner ear? And here's how you read the results. It's pretty straightforward. In a normal ear, air conduction is always better than bone conduction. But if there's a blockage, our conductive loss, the sound traveling through the bone actually bypasses that blockage and sounds louder. So if bone conduction wins, boom, we've just confirmed our suspicion of conductive hearing loss. Now, just to be sure, to really double-check our findings, we use Weber's test. This time, that vibrating tuning fork goes right on the center of the forehead. And the question is different. Which ear hears the sound louder, or is it the same in both? And here is the really fascinating kind of weird part. With conductive hearing loss, the sound is actually heard louder in the bad ear. You'd think it would be the opposite, right? But the reason is that the blockage in that problem ear also blocks out all the ambient room noise, so the vibrations from the tuning fork seem way more prominent. It's another solid confirmation. All right, we've got the patient's story, we've got the physical exam findings, and we've got the results from the tuning fork tests. We've collected all our clues. Now it's time to put it all together and finally solve this diagnosis. So let's lay out our evidence file right here on the table. We have a gradual hearing loss that both the patient's story and our tests confirm is conductive. We have that yellow, foul-smelling discharge that points to a chronic infection. And, importantly, No major red flags like vertigo or fever. The picture is getting crystal clear. And here it is. The diagnosis is chronic suppurative otitis media, we'll just call it CSOM. What that means in plain English is a long-term, stubborn infection of the middle ear space, usually happening behind a hole in the eardrum that just will not clear up on its own. Every clue we've gathered points directly to this. Now, getting the diagnosis is a huge step, for sure, but we're not done. Now we have to figure out what to do about it. So let's talk about the treatment and the really important takeaways from this whole case. But wait, there is one more critical piece of her story that we cannot ignore. It's a lifestyle factor, and it completely changes the game when it comes to treatment. She's a smoker. So why is this such a big deal? Well, because smoking is a direct assault on the ear's ability to heal itself. It messes up the tiny little hairs that help clean the middle ear, and it interferes with the eustachian tube, which is vital for keeping pressure normal. For any surgery to even have a chance of working, she absolutely has to stop smoking beforehand. It's a non-negotiable. The best way to fix this kind of CSOOM is with surgery. The plan has two main goals. First, go in there and clean out all of that chronic infection from the middle ear and the mastoid bone. And second, patch up that hole in the eardrum. This operation gives her the best shot at finally having a dry, healthy, and better hearing ear. So what are the big lessons here? First, a foul-smelling discharge from your ear is never, ever normal. It's a serious warning sign. Second, figuring out the type of hearing loss is a game changer for diagnosis. Third, things like smoking can have a massive impact on your ear health and your ability to heal. And finally, and this might be the most important one, this case is a huge reminder not to ignore symptoms that just won't go away. This whole case is a perfect example of how small, nagging symptoms can just be the tip of the iceberg, pointing to something much bigger going on underneath. It really leaves us with one final thought.